right, good morning, everyone. I'm Sabby. I'll be giving the senior lecture today. So I'll start with a case. Starts out with a urine CCT. You get a notification for, unfortunately, a 29-year-old female with a GSW to the head. GCS is 4, and ETA is 3 minutes. So you're the senior in CCT, so you call the level 1. You start assigning your roles. And you're the senior, so you're on airway because it's a trauma tube. So you grab your gyroscope because you're not sure if the C-spine is going to be stable, but then you have a DL prepared just in case. And so trauma team gets there, anesthesia gets there to back you up, and the patient arrives, and she is not protecting her airway, clearly. So you decide that you need to intubate. You ask your nurse to pull the RSI meds, which you decide upon etomidate and rock. So you push the etomidate, and then the anesthesia attending is like, she's not really responsive. You probably don't need to paralyze. And so you decide to give it a go. You get initially a pretty good view of your cords, and then upon trying to pass your tube, she starts biting the tube, starts biting her lip and her tongue, and now there's blood all over your airway. There's blood on the camera. You can't see anything. So at this point, you decide to take the tube out, you suction, you clean your camera off, and then you ask the nurse to push the paralytic that they pulled earlier. So now you go in a second time, and the second time you go in, you get a perfect view of your cords, like something like this. Maybe it's a little bit too perfect. And then upon trying to insert your tube, you get your tube in the mouth. You can see the tip of it on the screen, but it's just not passing. No matter what you do, it's just not moving the way that you want it to, and you can't get it to pass through the cords. So at this point, your hands are shaking. You look over at the anesthesia attending, and they graciously accept your plea for help, and they take over the tube, and they're able to pass it in like one really easy go, thankfully. So this was my first trauma airway as a senior, and it was horrifying. For some background, I really did dislike using the gyroscope. As a junior, I always chose DL whenever I was given the option because I was just a lot more comfortable with it. As a med student, I got to do an anesthesia rotation, so I got to DL pretty much every day for like a month. And then as a senior, I was like, okay, well, after this tube, I thought about it for days, and I was like, I'm going to have to do a lot more gyroscope airways in the next couple of years, so I should get good at this. So I reached out to our sim faculty, and they were able to set up a sort of session with me, and I got to practice, and I learned a lot of helpful tips. So disclaimer, this is not an airway lecture by any means, but this is just some of the things that I learned during that session, and then subsequent intubations and in my readings and my practice that I found pretty helpful and I wanted to share. So some of the things I'll talk about. So the reasons you might choose VL, specifically using the hyperangulated blade versus a standard geometry blade or DL. Some of the differences in technique between the two, and then how to obtain your optimal view, and then what that looks like. So in our ER, the hyperangulated blade that we have is using the gyroscope. And our standard geometry blade is going to be your Macintosh blade, which we use for direct laryngoscopy, but we also have the CMAC, which is basically the same blade shape, but it allows you to use video as well. So there are some reasons you might choose one blade over another. So for the hyperangulated blade in general, you're going to reach for it when you have an intubation that is going to require less manipulation of the head and neck. So in our patient population, the most frequently encountered patient that would benefit from this type of intubation is a trauma patient because you don't really know what the stability of their C-spine is. But also patients with rheumatoid arthritis, so you want to avoid subluxation of C1, C2. Any patient who has limited jaw opening, or otherwise if you just want to minimize manipulation of the airway itself as much as possible, such as patients with angioedema, or if you're otherwise expecting that the airway is going to be difficult. Standard geometry blade in general, one of the benefits is that it's a pretty quick setup. You could kind of argue for or against this, but you don't need it to be plugged in and charged. You don't need to roll the cart over from the other side of the room. It's pretty quick to set up. You can reach for it. Typically, if you're expecting a bloody or soiled airway, it's going to be beneficial because if you're expecting contamination, that is going to obscure your view, get your camera dirty, and so you might want to reach for this one first. Forearm body retrieval, technically you could use either, but just given the shape of this geometry blade, the standard geometry blade, the Macintosh, you have kind of like more room in the mouth to manipulate and kind of get your McGill forceps in there to retrieve the forearm body versus the hyperangulated blade, which takes up a little bit more room in the mouth. And then if you're otherwise expecting that the airway is going to be pretty straightforward, then you can just go for DL. Okay, so I'm going to go over the technique for intubating using a hyperangulated blade, some of the common issues you might encounter, and then some troubleshooting like tips. So from the very beginning, it's different. The way that you insert the blade, you're going to kind of go in the middle of the mouth. This is as opposed to DL, where you kind of go from the right side of the mouth and then you swing, you swipe the blade to the left to get the tongue out of the way. So from the very beginning, it differs. And then it's going to be important to really slowly advance the blade because it's very easy to overshoot, especially when you're first starting out or you're nervous. You kind of go in too deep, you completely miss the chords, and you end up either in a pool of fluid or tissue, and you really can't see anything. So the best way to get over this is to just reorient your blade and back out slowly so that, usually the tip then will end up in the vallecula and you can see your target. The other thing that's helpful to do with a hyperangulated blade is actually how you insert the tube in the mouth. So you're going to come in from the right side, but it's sometimes helpful to actually insert the tube with the curve facing the blade, like kind of like what's shown in the picture, and then advance that way. Once you see the tip, then redirect the tube so it's parallel to the blade. And the reason why this is actually helpful is because it avoids the tube bumping into the glide scope on its way into the mouth. Okay, this is super important. The way that you hold the tube is very important. So you want to actually hold the tube from the very top, the distal end. This gives you a lot more fine motor control and mobility as compared to if you were to hold it the way that's shown on the bottom, so kind of closer to the mouth. And it actually does make a big difference when you're intubating. And then let's say, you see your cords, you have a good view, you have your tube on the screen, and then you're just getting stuck kind of around here, around the posterior arytenoid cartilage. So there's this sort of mnemonic where it's like left larynx, right rings. If you're stuck around here, you're still in the larynx, what's helpful to try doing is rotating your tube slightly to the left and then trying to advance. And often that will get you over the posterior arytenoid cartilage. If you're past there and you're actually at the level of the cords, but the tube is not passing, what's probably happening is that the end of the tube is getting stuck at the tracheal rings at the top here. And so what you want to do then is actually try rotating your tube to the right and then advance that way. That's something that can help. And then if none of these interventions help, it might just be that the rigid stylet at the very end of the tube is just not giving your tube enough give. So at that point, you just want to stop advancing, hop the tube a few centimeters, and then try to pass your tube that way. Okay. So I think this is really important to go over because I don't know if it's something that a lot of us know when we're first starting out using the glide scope. Like the optimal view is pretty different from what you want to see when you're doing DL. So when you're intubating with a hyperangulated blade, you actually don't want your classic grade 1 view that you like for DL. You actually want more of like a grade 2 view. And you want to employ something that's called the 50-50 rule. So if you look over on the image on the right of the screen, you see how the cords are kind of like in the upper 50% of the screen. This is exactly what you want because you want the lower 50% of the screen available for tube delivery. This gives you a lot more room to manipulate your tube. While the view on the left is, looks like a little bit more appealing. You see your cords beautifully. You remember what I said earlier about your view being like a little bit too perfect? This is exactly what I meant. So what happens when you have this view, in order to achieve it, your blade actually takes up way more space in the oropharynx. And then you have some trouble passing your tube because you lose all the real estate that you would have had if you had your grade 2 view, and then you can run into issues that way. Okay. This is just to remind us all of the bougie. Don't forget to use, that you have this option available to you. And you can do this with a hyperangulated blade. There are some differences. So if you get your tube, and despite all the interventions and sort of troubleshooting tips that we just talked about, you still can't really pass the tube, what you can do is take a bougie and then just sort of bend the end of it so it takes on the shape of the rigid stylet, pass it through the cords, and then just take the endotracheal tube and thread it over the top. So it's pretty easy to do it that way. Okay. So the reason I brought up that case is because everyone who intubates either has or will at some point miss an airway. So it's relevant to each and every one of us, and I wanted to use it as a sort of stepping stone into this discussion. Um, as I progressed to my more senior years, I realized that seeing more patients actually exposes us to making more errors or failures. And so I wanted to talk about this because in medicine, failure is inevitable, which we all know. But in emergency medicine, it's a little bit unique because failure can lead to outcomes that range from trivial to absolutely devastating. And nobody is immune. So we have to figure out a way to deal with it. So Amy Edmondson, she's a professor at Harvard Business School, and she gives us a sort of framework for understanding failure and categorizes them into three. The first being preventable failures, which are exactly what they sound like, failures that are caused by something preventable. Usually it's something pretty basic like a lack of focus, inattention, or forgetfulness. So for example, maybe you're responsible for ordering a medication for a patient and you forgot to. Now that patient's been sitting there for hours waiting to be reassessed after getting a medication that was never ordered. Or maybe you ordered the wrong medication or you ordered it on the wrong patient. So how do we sort of get around this, or how do we improve from it? So the first step is to sort of acknowledge your mistake, move on from it, and make a plan for preventing this mistake in the future. In the case of ordering meds, for example, you can kind of create a mental check for yourself. Anytime you go to press the order button, condition yourself to look back at the patient's name and location to make sure that you're ordering it on the right patient. Complex failures tend to be something that is more systems-based. They still can affect us on an individual level. So for example, let's say there are a lot of specimens that are being mislabeled with incorrect patient information, but it's happening with multiple different providers, not just one person. So at that point, the failure may be actually the labeling system that we have to look at. Is the print large enough? Are there hard stops to verify patient identity, location, and multiple steps along the way? And then the last type of failure is something called an intellectual failure, which is most relevant to us on an individual level, and it's often the most painful. Intellectual failures happen when you don't know something, essentially. So you miss a diagnosis because you didn't add it to your differential, or you missed an EKG finding because it was not in your fund of knowledge of interpretation. So how do we learn from these failures? So reflect on the failure, take your time to process it and understand why it happened, and then take steps to prevent that from happening in the future. So depending on why it happened, if it was an issue of knowledge, then read, or if it was an issue of application or experience, then practice. So in order to be able to use failure to make us better, we need to be able to conceptualize failure as an opportunity, which helps us with two things. So one, it helps us put into perspective the failure as a gain rather than a loss. This helps us sort of with self-protection and preservation. So for example, saying to yourself, this was an unfortunate outcome, but if it hadn't happened, I may have never learned X, Y, and Z, and I would have missed it in future patients too. And then secondly, it helps us to improve and it prevents us from repeating these failures in the future. So in understanding how we can do so, it's helpful to understand this concept of a growth versus a fixed mindset. So I won't spend too much time here because I know a lot of us have learned this already or heard of it, but just want to talk about why it's important. So many of us, may carry beliefs of both mindsets and may oscillate between the two at varying times, but only having a growth mindset really helps us to improve from making mistakes. And so someone with a fixed mindset might believe that intelligence and talent is fixed or innate, and that failures define the individual. Feedback might be seen more as a personal criticism, and this kind of person or someone who has these beliefs at that time avoids challenges. Whereas somebody with a growth mindset believes that intelligence and talents can be developed, and that mistakes don't define you, but they're part of learning. They're able to separate failure from the individual, and they actually see mistakes as an opportunity to learn. So, in medicine, we are both learners and teachers. So, we'll encounter failure time and time again, either in ourselves or our learners. And in order to improve, we need to be able to foster this growth mindset in ourselves and encourage our learners to be able to do the same. So the person involved in the failure or who made the mistake should be able to say to themselves, I'm not my failure and I can learn from and improve from this. And then the person who's tasked with investigating the failure, this might be the senior resident or the attending or the person who's doing the RCA review, should be able to say this person is not their failure and we can all learn from and improve from this. This is something that's definitely not easy by any means, and it requires some practice. Um, so this is my sort of stepwise approach on how to deal with messing up, essentially. The first step is going to be to reflect and process. You should take the time that you need, and depending on the scale and impact of your mistake, you might need to spend a little bit of time doing this. And while you do this reflecting, you should employ a growth mindset, like we discussed. So I'm not my failure, and I can learn and improve from this. The second thing is to seek advice from somebody who has more experience than you. So for example, in my case, I had reached out to some faculty. A lot of mistakes or errors that you make, you can talk to your seniors, talk to your attendings, ask them what they would have done if they've encountered something similar, how they dealt with it, or how they prevented it from happening in the first place. And then finally, reading and practice. So for intellectual failures, like we talked about before, if they resulted from a lack of knowledge, that requires reading. And for those that result from a lack of experience, require practice. So how can we make this work in residency? Luckily, there are a lot of opportunities. So if there's a topic that makes you uncomfortable or is related to whatever mistake that you made, make yourself give a morning report on that topic or a conference lecture about it until it becomes like second nature information. When it comes to procedures, if you prefer the gyroscope and you really don't like doing DL, then do more DLs. If you hate LPs and you feel like you miss them a lot, and a patient that's on the board sounds like they might need one, just pick up that patient. Or if there's like a chief complaint that freaks you out, like dizziness or rash, definitely pick up that patient so that the next time it becomes easier to work through the differential or do that procedure. And then lastly, we should all have a way to sort of let off the steam after we leave work. So different things work for different people. For me, it helps to be able to vent to somebody or talk through my day. So I think everybody should have a person. For me, it's my husband. He's pretty supportive. Sometimes when I'm venting, it's almost like he's like meditating and really concentrating on what I'm saying, kind of like this. He's a very good listener. Or if you don't feel like comfortable talking with someone in your personal life, you can, there's a lot of people benefit from therapy, or maybe you don't benefit from talking at all and you need another way to sort of let off the steam. So exercising or baking or hiking. The most important thing is that you find something to release all that pent up energy from when you leave this place, and you'll like every single day, and you should feel a lot lighter when you go home.